Okay, for anyone on this panel, or perhaps even everyone on the panel, can you name one important factor for consideration that psychedelic therapy training programs around the nation should not miss? What's important in the training of a psychedelic practitioner? Dr. Dakwar, would you like to begin? I don't know how many microphones there are, but maybe we could just go that end to this end. But be quick about it because we probably have other questions. And if anybody wants to pass, that's fine. There's a lot of you.
Hi.
Hi.
Is this on?
It is.
Interesting you asked me that question. I was at a symposium earlier today where the same question was asked. And the response I gave didn't quite land well. I was asked about whether addiction psychiatrists should get additional training for psychedelic therapy with addiction, and what training programs are available that might be helpful. And, I think in this work, more generally, the vulnerability that these practices occasion, the liminality that occurs, require a great deal of sensitivity on the part of the practitioner that can also be cultivated in the work of psychotherapy, of sitting with people who are suffering deeply. But the level of sensitivity required when shepherding people through very intense states requires that we do a lot of work ourselves. And I would suggest anyone who's interested in this kind of work, be it a mental health professional or someone who wants to be available to friends, that they do a lot of work themselves, begin with introspection, with self-examination, with attending to their own relationship, to the recognitions that Roland was just talking about, and how fully we've incorporated those into our lives, how comfortable we are with the chaos of things. And it's through that work and learning that I think we can really have the privilege of the suffering of others being entrusted to us at that level.
Thank you.
Anyone else?
So this is a question for anyone who wants to answer it, but we should probably move along or it's going to take this whole Q&A session. I would like to give you a chance.
I did want to say one thing. I serve as the director of our master's program in psychoactive pharmaceutical investigation, and we thought really deeply about this question when putting together our curriculum. And two things I would say in addition to the wonderful comments are history and ethics need to be intrinsically built into any training program.
Dr. Sessa, you have anything to say about training? You look
yeah,
like you
sure.
might. Microphone.
I'm going to answer a different question, which is what don't you need to do? Because the question always comes up, should you have experiential experience with psychedelics to be a psychedelic therapist? In my opinion, it's a great bonus, but it's not essential. It's not as important as being a good clinician. So I get a lot of people who come to me and they go, oh, hi, Ben, I want to be a psychedelic therapist. And I say, why? And they go, because I love taking LSD. And it's like, that's not really the right answer. It should be because you love working with patients, with depression, with dissociation. You've worked for years in hospitals and wards and community settings and police stations and playgrounds, and you've got excellent clinical skills at helping people in difficult, distressed states. Psychedelic psychotherapy is a specialist bolt-on branch of psychotherapy. You need to first be an excellent, strong, powerful clinician because whether or not you've taken loads of LSD is not going to assist you as well in that difficult psychedelic experience guided session as somebody who's worked for years with patients with these diagnoses without psychedelics. So that would be my opinion. Having said that, we should also have experience with psychedelics to work with them. But for me, it's number two after being a great clinician in the first place.
I've got a question for Dr. Dolan and Dr. Pittenger, which is, where do you consider autism and other neurodivergent conditions to lie on the trauma-related diagnosis spectrum? We haven't talked about autism at all, and somebody should. So if anyone feels comfortable, please jump in, because Alicia Danforth is not here.
Okay. Well, I mean, I've been actually studying autism for 30 years, 25, 30 years, a long time. And I mostly have focused on genetic causes of autism. So the first identified cause of autism is Fragile X syndrome, and it's currently still the leading identified cause, affecting about 5 to 6% of people. So that's really my expertise. And you know, my PhD work really focused on trying to understand what was the pathophysiology of the disease. And I have to say, there is a little bit of evidence there that that disorder may represent a failure to properly close critical periods. And so while I think that there are acute subjective effects of drugs like MDMA that may reduce the social anxiety, I don't think that's the core symptom of autism. And I think that we need to be really careful about jumping in to try and treat core symptoms of autism, especially if it turns out to be that psychedelics are reopening critical periods and autism is a failure to properly close them. So I think a lot more work needs to be done. I can tell you, when I first got into psychedelics, my motivation is that we had discovered that another target, the metabotropic glutamate receptor, might be a good target for treating the disease. And in like 26 trials in animals, it seemed to be working, and everybody got super excited about it, and then it failed in clinical trials by Roche, Pfizer, Seaside. A bunch of companies tried, and something like $250 million were spent on this approach, and it failed. And at the time, the entire, pharmaceutical industry walked away from autism because it was seen as sort of like, this is going to be the goal. This is the mechanism-based therapy, and this is going to be the moonshot that we've all been wanting. And we noticed that while all of the all the preclinical trials were done in early development, all of the human trials were done in late development, so in adults. And so we have this insight that maybe the reason that the human trials failed but the mouse trials succeeded is because we intervened too late. So that was originally my idea, but again, it's this idea of adjunct therapy. So the idea that we are pursuing currently in my lab is that we would pair the mGluR antagonist, which we think is the right therapeutic target at the biochemical level for this cause of autism, with the adjunct of psychedelics to reopen the appropriate critical period once we've corrected the biochemical, underlying biochemical problem. So that's the way that we are approaching it.
Dr. Pittenger, does anyone else want to talk about autism or neurodivergence?
I want to respond to the part of the question which said, where does it land on the trauma spectrum,
Yeah.
right? So I loved your talk about trauma, but I would add a wrinkle. I think that much of what I agree that our diagnostic categories are garbage, but I think that the trauma, childhood and as well as adult trauma, interacts with individual substrates. The same trauma can have a very different effect on one person than on another because of other aspects of their personality, be those developmental or genetic or other aspects of their developmental experience. So in autism, there is a very early neural maldevelopment where things are going on a different line of development, and that can be in a wide spectrum of different divergence from neurotypical. And then there's a feedback process where people's experience, children's experience, is different because they're not fitting into the social environment in a neurotypical way, and that leads to a developmental feedback over time, which ultimately results in the symptomatology. So I have no data and no way to know, but going to the question, my intuition would be that if the neural divergence is mild, in a less strongly affected case, there may well be a role for psychedelics, not to get at the core, often genetic origin of the difficulty, but to get at some of this traumatic feedback that's happened over the course of development. Whereas if the core neural difficulty, developmental difficulty is fundamental, I think it's rather unlikely that there'd be a major benefit. That's purely speculation, but that's how I would think about trying to address the question, to design questions to then be asked empirically.
Understood. This is for Haley Gilmore. What ITT protocol would you most like to see show up in your inbox next?
Is this on?
Tis.
Well, there's actually one that's been sitting in my inbox for a while. I don't know if Darren's in the room, but there's a protocol looking at race-based trauma that I'd be really interested in activating.
Good. Good answer. Sorry, I'm just scrolling through to see. For the Sundown Cancer team, were there additional measures in pain diminishment outside of psychological reframing? Like any objective measures of decreased pain? Is that team not here? Pardon me, then. That's not going to get answered. Here's a question up for grabs. What do you expect some of the patient's subtypes might be when exploring who might benefit most for a given psychedelic? A lot of these questions are, okay, we've got a lot of patients, we have a lot of psychedelics. How do you match who gets what? Ben, I mean, I think it was you who were saying, like, try them all, see which one you like, and work with that. Does anybody have any other suggestions for how we're sort of matching patient population to psychedelic treatment?
I mean, I agree mostly with that, but I would just add that, there might be indications where it makes sense to, like, if this critical period idea holds up, that, I don't think it's an accident that people have been using ibogaine for heroin addiction. That's sort of a really entrenched, recalcitrant set of memories that maybe need a longer open state of the critical period to really rework those memories. Whereas, maybe for cigarettes, psilocybin is, shorter and good enough. I also think that, as we explore this space, there might be opportunities for combination therapies, combining a meditation plus ketamine, or 2 ketamines and an MDMA, or even, we don't have any evidence actually to support the idea that microdosing reopens the critical period, but it might be that it starts to loosen things up if you do it for a month and then you go into something to prepare the patient. So we just don't have the resolution to measure that at this point, but I can imagine those kinds of combinatorials as well.
And one follow-up, Dr. Dolan, is DMT, 5-MeO DMT, pretty short-acting, 15, 20 minutes, 30 minutes. My assumption is that would be a more narrow window, but you didn't work with those.
We didn't work with those, and I think I get this question almost every time I talk. I think it's a great experiment. I think that my prediction would be that as DMT, inhaled or, very short acting, it would only open the critical period for a very short time. Whereas if it's given as ayahuasca, my prediction, it would open it for, much longer. And so I don't exactly have a receptor level explanation for that, except that I have this intuition that all of the psychedelics are, in some sense, sitting in their receptor too long and triggering the cell to say, pull them in. Because neurons are extremely sensitive to neurotoxicity. And so when something is activated too much, they have mechanisms in place to hit the reset button. And I think that reset button is a little bit, I suspect, is related to why it reopens these critical periods. So I don't know in the case of DMT whether that would be at the level of the receptor or at the level of clearance from the synapse, but that's my hunch, but untested.
I'm just imagining mice, puffing on their DMT vape pens versus, going back up for a second or third cup during ceremony, and you could compare those two.
Well, the reason we don't do that, is that mice can't vomit.
They cannot vomit.
They cannot vomit.
Well, where's the fun in that?
So we're just worried that they're going to have a terrible, terrible trip feeling nauseous for, 8 hours.
Dr. DeBoer, I believe you have something to say?
Thank you. Yeah, what I'd like to add to
The mic
Gul's...
right up to your face.
Okay, is this better? Okay, great. What I would love to see, and we're talking about combination and, addition to what Haley was saying. So in our clinical trials, so previous suicide attempts are okay, not within the last 6 months prior to enrollment. I would love to see a trial with, for example, IV ketamine in active suicidal ideation, and then right after starting a whole protocol with MDMA-assisted therapy. And the second thing I want to say, we think is really important for the field, we wish we were able to predict very clearly for which patients MDMA-assisted therapy works and which not. We owe that to the field. But we don't have that information yet. Maybe what you asked me this morning, when post-approval we have more patients, we can predict that, because that's what you need, I think.
Drug combinations. Nobody really talked about candy flipping, this idea of combining psilocybin and MDMA or LSD and MDMA. If anyone feels comfortable addressing that, it wasn't brought up today and it probably should be.
I'll talk about that.
Will you?
I mean, I think this is like you said, Karina. It's the future. It's also I think we can take our cues here from recreational drug use. Recreational drug users are not stupid. They know what they like and they know what works for them, and they choose their drugs over time. Some people love ketamine, some people love MDMA, some people love magic mushrooms, some people love all of them. Some in combination. Some people like to take MDMA and then as the sun comes up, drop some acid. I think we should look at these as a massive epidemiological study of anecdotal data, because also they know how to do them safely. Most people take most drugs most of the time benignly, and that's really important. And I think we're going to start getting these. So going back to the original question, which drug for which thing? I know when I spoke there very broadly and grossly that they're all the same and it doesn't matter. I think what we'll find is let the patient lead us. So I've got a patient at the moment with bulimia nervosa, and she's responding brilliantly to ketamine, because for the hour that she's under ketamine, she has no body. And I was talking to her and I was saying, your whole life, it's been about, am I too fat? Am I too thin? The lumps here, the bumps there. It's every waking moment. And for that hour, you have no body. I said, you're a useless lump of meat lying on the bed. I'll look after your useless lump of meat. Off you go on your journey. And she comes back and she just said, what a wonderful holiday. I just had an hour away from this thing that's been bothering me the whole time. Now, other people can't stand ketamine. They love MDMA. So let's let the patients lead us. Let's get all of these medicines approved so we can make meaningful decisions with the patients writing their own bespoke care plans. It's going to be how it's going to be.
Love it. If anybody really wanted to say something, didn't have a chance, and they're itching to add to their presentation, this is a perfectly good time to grab a microphone and, say your 2 cents or your 2 bits. If anybody, I think something that a lot of people have been talking about is this issue of whether you need a mystical experience or a spiritual experience in order to benefit. If anybody wants to talk about that, or boundary violations, anything that you are called to speak about while I look through this list.
I'd like to make a comment on the question of whether the psychological experience or the neural mechanism is what matters, because I am actually troubled by that question. It gets asked all the time, and it's a troubling question because there are 2 options. Either we're dualists, and we think that important stuff is happening on the spiritual realm that's totally inaccessible to scientific inquiry, or we believe that psychological experiences are neural experiences. in some kind of very complicated way. Now, no surprise, I'm in the second camp as a matter of faith, because I can't prove it, but as a working hypothesis. And that means the question, is this a psychological experience or a neural experience, actually doesn't make any sense, because it has to be both. Every psychological experience has to have a correlate in the brain, in ridiculously complicated ways that we're not even close to understanding. And maybe the same psychological experience can have two different, there's a huge amount of complexity there, but there has to be a relationship. And no, I won't say every neural event has a psychological correlate, because there's plenty going on in the brain that doesn't affect our conscious experience, but many neural events have a conscious correlate. And so I think we need to carefully examine that question. I think a perfectly good question is a mystical experience considered together with its neural correlates causally necessary for the for the antidepressant or other therapeutic effects? Can those be dissociated? That's a perfectly good question, but it's not a psychology versus neuroscience question. I think I think we need to carefully examine and thoughtfully reframe that somewhat glib question, and in order to get to a non-dualist, much more interesting set of questions that we can attack as a field.
Yeah, I'm glad I followed up, because this is a perfect follow-up. I think an interesting way we can reframe that is to ask the question about whether the experience itself is the psychological substrate, or whether the memory of the experience itself and then the reflection on that experience during the integration sessions is what's happening. So there is a potential way to dissociate what's happening at the neural level during the experience versus what's happening during that post-experiential period and reintegration.
That's interesting.
I just want to say something about that. We actually have a little bit of data to support the idea that the context matters, right? So I don't think of it as mystical or not mystical. I think of it as context, or as, people who do human research talk about set and setting. We find that my social critical period only reopens in a social context, not in an isolation context. And we think that that social context matters because the critical period we're trying to open is social. But if we were trying to open a motor cortical critical period, then I don't think the social matters. I think it will be the set of motor memories that need to be co-activated both during the journey and once they become reactivated in that open state. That engram, which is a neuroscientific term for describing the set of neurons and synapses that encode a specific memory, that engram that is activated during this open state becomes available for modification. Okay, and so I think it's both of those things.
Isn't that engram also a Scientology word?
I don't know. I don't know anything about Scientology, sorry.
Oh, good answer. Do you have something to say, Albert?
Yeah, I was not going to comment on Scientology, but I was just going to say, I agree very much with what Chris was saying, which is, this is a two sides of the coin thing. And I've worked with lots of people who have had a lot of benefit, who have not had mystical type experiences, but who have had insightful experiences, who have had cathartic experiences. And so there's just there's a range of psychological experiences that people can have. And I think that those are often very important, particularly when you're dealing with psychiatric conditions. And so when we're talking about Emmanuel's work, where the mystical experience was clearly not correlated with the effects of reducing headaches and migraine intensity, then you got potentially a different mechanism going on. But that doesn't mean that either or. It definitely means that both is happening.
There's a question about somatic therapies and sort of combining things like somatic experiencing therapy with psychedelics. Is anybody comfortable talking about somatic therapies and their place in psychedelic treatments? Crickets. Okay, well, just know that it's a thing. I believe that this is important. And, being embodied, having body work, the combination of either MDMA or any other psychedelic with somatic focused therapy, to me, makes a lot of sense.
IIT.
It's submit an IIT. I'm not submitting any ITTs, but I appreciate the idea. Someone should. Look at that. Any other last words? As somebody has a question, like, what would you tell somebody who is interested in coming into this field? What do you need to do? Ben, you already sort of gave a pretty good answer for that, but it sounds like you have something you'd like to say?
I was just going to say something about this issue of taking the psychedelic effects out of psychedelics, because it's come up, and also taking the spirituality out of psychedelics. And I think, as a clinician, I don't really care what things are called. I don't really care how they work either. I just care whether they work. What's kind of been interesting in the debate with the psychedelic community in recent years is that you can't take the psychedelic effects out of it. And I've even had someone at a conference say to me, "Doctors, get your hands off our sacred molecules." It's like, well, for a start, they're not your sacred molecules. And what's weird about this, and the hypocrisy of this, is we all in this community hold our hands up to Sasha Shulgin, who was the most wonderful, beautiful person and most wonderful chemist. And what do you think he did for the whole of his life but tweak psychedelic molecules? He loved methylating this, ethylating that. He really loved it when he came up with something with no psychedelic effects. So it's all about accessibility for patients. If we can come up with some analog of LSD or some analog of psilocybin that you don't feel and has no psychedelic effects, but it treats knee pain, great. It's just clever, creative pharmacology. And it's both and, not either or. So it's all about accessibility, not what we call things, or not even how they feel or how they work.
Okay, last chance for last comments. Anybody?
I'm sorry, I just have to say one thing.
Anybody except Cool? No, sorry. Go ahead.
Okay, as we do this, however, as we look for, clinical endpoints, I think it's important that we understand how they're working in the first place, right? So we heard a talk about, psychoplastogens, which, I actually hate that term. And the reason I hate that term is because the best psychoplastogens that we know of are cocaine, heroin, alcohol, nicotine. All of the drugs of abuse are intense psychoactive plasticity inducers.
Yeah.
And so if we are taking ibogaine and getting rid of the psychedelic side effects and then measuring our success based on their ability to induce plasticity, and what we've decided is an appropriate measure of their therapeutic efficacy, namely tail suspension or, water floating, we could be taking a drug that has this remarkable ability to cure addiction and turning it into an addictive drug that is merely a next generation SSRI and not doing the intense therapeutic effects that we are so excited about and why most of us are here on the stage today.
Okay. If any of you dozen people who hasn't spoken would like to add anything, speak now or forever hold your peace. Peace held. I'm going to turn the microphone over to Kevin Balkdick.
Thank you all for making it to the end here. We're really grateful for your presence. We're very, very grateful for all of the wonderful researchers who made it here today. I hope everyone will bear in mind the discussions we had this morning about keeping the big picture in mind. And we hope that you'll all join us tomorrow morning where we talk about putting all of this into practice. Thank you all so much. Enjoy your Friday evening, and we'll see you tomorrow.